Next is Dr. Kristin Dayton. Dr. Dayton?
Yes. Excuse me. Good morning, Board of Medicine and Board of Osteopathic Medicine members. Thank you for inviting me to be a part of the discussion on the development of practice standards for the treatment of gender dysphoria in Florida. Please note my testimony reflects my own personal judgment and is not the official position of my employer. My name is Dr. Kristin Dayton, and I am a board-certified pediatrician, a board-certified pediatric endocrinologist, and a member of the Florida chapter of the American Academy of Pediatrics, which represents more than 2,600 pediatricians across our state. I received my medical degree from Wake Forest University and completed pediatric residency and a pediatric endocrinology fellowship at the University of Florida Children's Hospital. I am the medical director of the University of Florida Children's Hospital Gender Program. I'm an assistant professor at the Division of Endocrinology, Department of Pediatrics, and U.S. Medicine. Today, as the practice standards for gender-affirming care are considered, I will speak about my expertise and knowledge of the standards of care for the use of puberty suppression and gender-affirming hormonal therapy. UF's Youth Gender Program launched in 2016, and I have been involved as a clinician in the program since its inception. Our program serves transgender and gender-diverse children and adolescents from throughout Florida and provides education to youth and their families about gender identity development, gender nonconformity, psychosocial support, and when indicated medical affirmation. The program's multidisciplinary team, which includes 2 board-certified pediatric endocrinologists, 1 board-certified pediatrician, a psychologist, a psychiatrist, 2 patient advocates, and a medical legal partnership, provides developmentally appropriate, evidence-based, gender-affirming care to children, adolescents, and young adults diagnosed with gender dysphoria and their families in a safe, inclusive environment. Gender-affirming care interventions fall along the continuum, and the risks and benefits of potential interventions are discussed in an open, respectful manner with each patient and family, with no end goal in mind other than providing the best care for each individual patient. The program utilizes national and internationally recognized standards of care developed by the World Professional Association for Transgender Health and the Endocrine Society. I have years of clinical experience in this area and have cared for over 300 patients during this time, and my recommendations are based on evidence-based standards combined with practices gleaned through my experience in this area. My primary role as a physician is to provide clinical care, and I have the most clinical experience of anyone in this room in providing evidence-based hormonal care for youth and young adults with gender dysphoria. I was initially drawn to working at this clinic after experiencing the joy it brought to people's lives to be affirmed and respected for who they were. Throughout my time with this clinic, I have seen the struggles that our patients face, but also have witnessed them block them when they are able to be affirmed. I always think of one of our patients who would hide his face every day in online classes during the COVID pandemic, since he would not feel like how he looked on the outside matched how he felt on the inside. Fast forward 2 years later, with the addition of testosterone therapy as well as affirming mental health support, he's happily back to in-person school and is considered the class clown. Our patients report reduced suicidal ideation and improved satisfaction with their lives after being able to access gender-affirming hormonal therapy. Parents talk about how their children interact more at home and are finally more themselves after years of being closed off to the world. Children and adolescents with gender dysphoria experience challenges such as bullying, discrimination, harassment, and lack of social acceptance that increase their risk for experiencing depression, anxiety, and other mental health conditions. The high rates of discrimination experienced by transgender youth lead to a greater risk for suicidal ideation and attempts compared to their cisgender peers. A large-scale study of suicidality in adolescents found that up to 51% of transgender adolescents reported experiencing suicidal behavior, compared to just 10 to 18% of their cisgender peers. And providing medical care for children and adolescents diagnosed with gender dysphoria, a specialized approach is recommended. Gender-affirming care is a model that includes assessments and customized care practices to meet the specific needs of each child or young adult experiencing gender dysphoria. There is no one-size-fits-all model of care, nor are the needs of every child experiencing gender dysphoria the same. The guidelines and standards for gender-affirming care are set based on scientific data and evidence and are medical treatments necessary to treat the conditions of gender dysphoria. Gender-affirming care standards are endorsed and recommended by the American Academy of Pediatrics, the Florida chapter of the American Academy of Pediatrics, the American Medical Association, the American College of Obstetricians and Gynecologists, the American College of Physicians, the American Psychiatric Association, the American Psychological Association, the American Academy of Family Physicians, the American Academy of Child and Adolescent Psychiatry, the Endocrine Society, the Society for Adolescent Health and Medicine, the Pediatric Endocrine Society, the World Professional Association for Transgender Health, or WPATH, and many more organizations committed to providing the best evidence-based care. As stated previously, evidence-based standards of gender-affirming care recommend that each child and adolescent diagnosed with gender dysphoria is provided an individualized treatment plan that incorporates medical, mental health, and social services to provide care and support to the child or adolescent and their families. In some cases, pubertal suppression and gender-affirming hormonal therapy are indicated treatments. Adolescents may be prescribed pubertal suppression or other hormone therapy to alleviate stress that may occur with the development of secondary sex characteristics. The decision to initiate puberty suppression is not automatic, nor is it applied to every treatment. Puberty suppression treatment occurs after the child experiences a prolonged and persistent gender dysphoria. And the decision to initiate treatment is made in concert with the adolescent, their family, and the medical and mental health care team after a careful discussion of risks, benefits, and alternatives to treatment. Strong evidence supports pubertal suppression for gender dysphoric adolescents. A study in the well-respected, peer-reviewed Journal of Adolescent Health examined adolescents who were referred to a gender clinic but had not yet begun undergoing gender-affirming medical care, including pubertal suppression, and adolescents who had already begun receiving gender-affirming care using pubertal suppression with cisgender adolescents. The researchers found that adolescents with gender dysphoria had worse psychological health compared with their cisgender adolescent peers, and that after receiving pubertal suppression as part of gender-affirming care, the adolescents with gender dysphoria had similar or better psychological health when compared to their cisgender peers. A study in the high-impact journal Pediatrics found that transgender adults who wanted and were able to access pubertal suppression as adolescents were less likely to have lifetime suicidal ideation when compared to transgender adults who were not able to access pubertal suppression as adolescents. Overall, the studies that have examined the use of pubertal suppression as a component of gender-affirming care demonstrate that the use of these medications is evidence-based. Following the delay of puberty, adolescents may benefit from initiating gender-affirming hormonal therapy. This decision to treat is made with their parents or caregivers and is never made in isolation, but is again made in the best interest of the patient at heart and in a team-based approach. Just like the decision to initiate puberty suppression, and the decision to initiate gender-affirming hormone therapy is highly individualized. Gender-affirming hormone therapy clearly lowers the chance that adolescents diagnosed with gender dysphoria will experience depression or suicidality. I'm happy to provide these references as well. In summary, children and adolescents diagnosed with gender dysphoria deserve the best evidence-based medical and mental health care available. The medical community has endorsed gender-affirming care as an evidence-based treatment for gender dysphoria. By proposing to develop an alternate standard of care for the treatment of gender dysphoria, Florida would ignore the broad consensus of the medical community and the weight of peer-reviewed literature. The role of the Board of Medicine is to ensure that every physician practicing in the state meets requirements for safe practice. To our knowledge, no other Board of Medicine has prohibited their fellow physicians from following evidence-based national and international guidelines. The Florida Board of Medicine should reject the call for the development of new standards of care for the treatment of gender dysphoria and allow pediatricians, child and adolescent psychiatrists, psychologists, and other physicians and mental health providers to continue to provide gender-affirming care under the existing standards. I'm happy to take any questions the board may have about the youth gender program, the current standards of care for gender-affirming care, or the evidence supporting gender-affirming care. Additionally, my colleague, Dr. Brittany Bruggeman, who also provides care in our clinic, is present with me today and would be happy to answer any questions the board may have regarding our expertise. Thank you.
Okay, thank you, Dr. Dayton. Any board members? Hey, go ahead, Dr. Hunter.
Dr. Dayton, can you hear me?
Yes, thank you.
Do you all keep data on the patients in your clinic?
The question was, do we keep data of the patients in our clinic?
Correct.
We don't have an active registry of our patients currently.
Okay. You had mentioned that one size does not fit all, correct?
Absolutely.
Okay. Can you just, off the top of your head, what percentage of kids who present to your clinic are placed on puberty blockers?
I would say like probably 30%.
Yeah,
Okay.
I would have said 20 to 30.
And what
And there are ways to pull this data. So even though I'm not actively collecting data, we do have some, we use electronic medical records, and we have some ways that we could pull some more specific answers to your question. So I'm happy to do so.
And of those, what percent would you guess go on to cross-sex hormones? Dr. Biggs had mentioned, and I think most of the literature shows 96 to 98% of kids placed on puberty blockers go on to cross-sex hormones. So what, do you have a feel, since you don't keep data, what your...
I would agree that the vast majority that start puberty blocking do progress to wanting to receive gender-affirming hormonal care, which would be a testosterone or estradiol typically.
And then could you just talk about the difference between suicidality and completed suicide?
I think that would probably be a better question for our mental health experts. But my general impression is that suicidality is a thought and feeling that someone has, and a suicide completion is clearly when someone has died from suicide.
And do we have data on those regarding children and youth with transgender identification?
I'm sorry, I couldn't understand that.
Do we have any data regarding the true suicidality risk and completed suicide risk?
From our clinic,
From the world, from anywhere?
I think that there have been many studies looking at suicidality on a national and international scale in this population. Typically, these are population-based studies and survey-based studies. So as much as we can trust those types of studies, we do have data on that.
Chairman, I was wondering if we could bring Dr. Biggs back on, because I think he has done research on the difference between suicidality and completed suicide.
Let's finish her presentation, and then we can bring him later, because others will be out of order too many times.
Okay.
I think Dr. DiPietro.
Thank you. Dr. Dayton, can you hear me?
Yes, I can.
So I want to clarify one thing, because I think one thing that you said is extraordinarily important, and what I really want to get my point made today on this is, from your perspective, the current guidelines, research, the current perspectives we should all be taking on this is that it's a multidisciplinary team approach. Therefore, the pediatrician, the pediatric endocrinologist, psychiatry, and psychology should all be involved in a team approach when discussing hormone and gender therapy, correct?
I would say in specific, from the data that I've seen and from the guidelines we have, it is in relation to youth that I would make that recommendation. But yes, for transgender youth, it is recommended to use that sort of a team-based approach.
Yeah, and I think personally, and in looking at most things in medicine where you're, and I'll use something as simple as bariatric surgery as an example. Even bariatric surgery, transplant recipients all must have a team-based, multidisciplinary approach, because these are very big and important things that we are doing. And so just as a reference, a patient cannot even get a transplant unless they have been deemed that they have a support system at home, that they're able to follow up on their care. And I think that this is very important, and I think when we're discussing this today, we need to keep in mind that this is really no different. This should be very much a multidisciplinary approach. Thank you.
I would agree, and I would just also want to say, I don't know that those sort of procedures and surgeries have special rules from their boards, from like the Board of Medicine. And I think in the same way, if we are to trust our doctors in our state, we are following those guidelines in that same way.
Yeah, Dr. Hunter?
Dr. Dayton, one more question. You mentioned quite a few studies. I was wondering, you're familiar with the systematic reviews out of Sweden and out of England, the NICE reviews on puberty blockers, cross-sex hormones, and out of Sweden, the SBU evidence review team there. And then they found all of these studies to be of low quality, very low quality, low certainty of the evidence. I was wondering if you could comment on those reviews from those countries.
Yeah, thank you. I have familiarized myself with those reviews, and I've looked through the base evidence that they are reviewing, and I think that there are also very good studies, and there are also reviews saying that there is evidence to do this there. So I actually welcome you guys to listen a little bit more when Dr. McNamara speaks about the type of evidence and reviews and how we can interpret those.
Thank you. Is there any board members, any questions? If not, Dr. Dayton, thank you so much for taking time away from your work and addressing this group on a very, very important matter. Thank you so much.